physiological changes during pregnancy. In this part, we'll see the physiological changes in the reproductive tract, urinary tract, and alimentary tract. So let us start from the reproductive tract. In order to accommodate a rapidly growing product of conceptus, the uterus undergoes significant enlargement in size. The weight of the uterus is estimated to be nearly 1,100 grams at term. Uterine enlargement is due to the myocyte hypertrophy and the fibrous tissue deposition. This is result from the hormonal stimulation and the distension of the uterus by the product of conceptus. The uterine enlargement is not symmetrical. It is more marked at the fundus, and the part of the uterus where the placenta is implanted grow faster than the other part of the uterus. The volume of the endometrial cavity also increased during pregnancy. It reaches up to 20 liters. As you know, before pregnancy, the endometrial cavity volume is estimated to be around 10 ml. So it is increased by 500 to 1000 times during pregnancy. The wall thickness also vary during pregnancy. Early in the pregnancy, the uterine wall becomes thicker. As the pregnancy progresses, it becomes thinner. At term, the wall thickness is estimated to be 1 to 2 centimeters. During pregnancy, the uterine musculature is arranged in a strata, and the outer hood-like layers, which arches over the fundus and extends to the varus ligament, and the middle layer, which is the main components of the myometrial layer. It is mainly composed of a dense of myometrial fibers perforated in all directions by the blood vessels, and the cells in these layers has two curvatures. Interlacing of the two gives an approximately a figure of 8 appearance. This appearance is very important to control the bleeding after delivery. When this fiber contracts, it forms ligatures to the vessels perforating these fibers. Internal layers is the sphincter-like fibers around the fallopian tube orifice and the internal cervical os. The shape of the uterus early in pregnancy, it retains it is piriform or pear-shaped, and later in pregnancy, around 12 weeks, it becomes globular and spherical in shape, but later in pregnancy, it assumes as ovoid, since the length grows faster than the width. By the end of 12 weeks, the uterus ascends from the pelvis to become an abdominal organ. At this time, it rotates toward the right because of the presence of the sigmoid colon on the left pelvis. There is also Braxton Hicks contraction during pregnancy. This is an irregular, painless, non-rhythmic, infrequent uterine contraction that occurs pregnancy. It was reported to be as early as second trimester of the pregnancies, and the number increased in the last 2 weeks. This contraction is different from the labor contractions because it doesn't change the cervical. It doesn't change the cervix, okay? The uteroplacental blood flow, it is increased during pregnancy significantly. This increment is regulated by the endovascular trophoblastic invasions. This means that during pregnancy, around early in pregnancy, the uteroplacental vessels, mainly the spiral arterioles, the smooth muscles in this wall is replaced by the the trophoblastic tissue. This makes the vessels more capacitance and highly distensible vessels. This will increase the blood flow to the uterus. The other factor contributing for increased uteroplacental blood flow is the vasodilatation mediated by the nitric oxide, progesterone, and other hormones. The third factor is these vessels were resistant to the pressure effect of the angiotensin II and the epinephrine. So because of these three factors, the uteroplacental blood flow significantly increased during pregnancy. In the cervix, as early as 1 month after conception, the cervix begins to undergo softening and cyanosis. This will cause the presumptive sign of the pregnancies like Chadwick sign, Hager sign, and the Godel's sign. Arrangement of the collagen-rich fibrous connective tissue is necessary to keep the pregnancy, for cervical dilatation and repair of the cervix after protrusion. As you know that the cervix is mainly composed of the fibrous tissue, 90%, only 10% is formed by the smooth muscles. When we say cervical ripening before occurrence of labor, there is a connective tissue remodeling. That is, the collagen and proteoglycans were decreased and the water content were increased compared with the prior to the pregnancy. The cervical gland undergo marked proliferations, hypertrophy and hyperplasia, and at term the cervical gland accounts around 50% of the cervical mass. This gland will produce tenacious corpus, immunoglobulin and cytokine rich mucus, which obstructs the cervical canal immediately after conception and plays an immunologic barrier to protect the uterine content against infection. The ovaries, ovulation season, and the maturation of the new follicles were suspended. A single corpus luteum functions maximally around 6 to 7 weeks of gestation. So, excision of the corpus luteum around 6-7 weeks of gestation will result in rapid decrement of the maternal serum progesterone level, and it can cause spontaneous abortion. But around 8-10 weeks of gestations, the progesterone production by corpus luteum will be replaced by the placenta. So excision of the corpus luteum later in pregnancy will not cause these complications. So let us see the vulva. The vulva becomes edematous and more vascular. This increased vascularity of the vulva will result in superficial varicositis in multiparous women, which appears as dilated tortuous vein. Most of the time it is asymptomatic and resolves after delivery. The labia minora becomes hypertrophied and increased pigmentation. The vaginal wall becomes hypertrophied, edematous, and more vascular. The length of the anterior wall of the vagina is increased during pregnancy because the cervix is pushed along with the uterus upward. Leukorrhea gravidarum, it is a whitish watery secretion that increased during pregnancy because of increased blood flow to the vagina. As you know that the vagina has no mucous gland, it is transudate secretions where results from subcapillary venous plexus. So the vaginal pH becomes acidic, it is 3.5 to 6. This plays an important role in preventing multiplication of pathogenic organisms around the vagina. The breast, early in pregnancy, the breast tenderness and paresthesia can occur, and the nipple becomes larger and more deeply pigmented and erectile. Colostrum can also be expressed from the nipple by gentle palpation. This is a yellowish fluid secreted from the nipples. It starts to appear around 16 weeks of gestation. It is not associated with the preterm deliveries. Pre-pregnancy breast size and ultimate production of the milk is not correlated because there are several factors that affect milk production. So the urinary system. Let us see the anatomical changes. The kidney size grows approximately 1 centimeter in length, and the weight of the kidney is also increased during pregnancy. This is due to 3 factors. 1, due to increased renal vasculature, due to increased interstitial volume, and increased urinary dead space, causing this enlargement in size and weight. The dilatation of the ureters, renal, pelvis, and calyces begins in the second month of pregnancies and peaks in the middle of the second trimester. Why this dilatation? 2 reasons. 1, progesterone-mediated relaxation of the smooth muscles in the wall of these structures, and the other is mechanical compressions by the enlarged graviduterus and the dilated venous plexus of the ovaries. This dilatation is more marked in the right ureter than the left. This is because of marked compression of the right ureters by dextrorotated uterus. What is the clinical significance of the ureteral dilatation and dilatation of renal, pelvis, and the calyces? Their clinical significance during pregnancy, because of this dilatation, the risk of pyelonephritis is significantly higher in a pregnant woman having asymptomatic bacteriuria. And also because of this dilatation, interpretation of the urinary radiographs may be changed. By 6 weeks postpartum period, this ureteral dilatation resolves. On the bladder, elevation of the bladder trigon since the mid-pregnancy. Because of this elevation of the bladder trigons, torsicity of vessels with all over the bladder, causing idiopathic hematuria during pregnancy. The bladder capacity also decreased because of the compression by the graviduterus. As a result, there is an increased urinary frequency, urgency, and sometimes incontinence. Renal hemodynamics, the renal plasma flow increased by approximately 80% before the end of the first trimesters. It begins to rise during the luteal phase before implantation, and it is continued to rise until 34 weeks of gestation. But after 34 weeks, it is decreased by 25%. This increased renal plasma flow is due to the renal vasodilatations as a result of nitric oxide and progesterone. The glomerular filtration, it is increased in general during pregnancy. At the end of the first trimester, it is 50% higher than the non-pregnant value, and it's continued to rise until term. It is increased due to increased renal blood flow and the decrement of the plasma oncotic pressure in the glomerular microcirculation. What is the effect of renal hyperfiltration? Reduction in the plasma level of creatinine, BUN, and the uric acid, and also increase the urinary excretion of protein, glucose, and the water-soluble vitamins and minerals were at a greater extent excreted through the urine because of this renal hyperfiltration. This GFR will normalize 3 months postpartum. In general, the urine volume is also increased during pregnancy, and the nocturia is also common. So let us see the alimentary tract. Most women experience an increased appetite during pregnancy, and the sense of taste may be blunted in some pregnant women. Let us see what pica is. Pica is a bizarre craving of strange food. It is relatively common during pregnancies. Examples of picas are consumption of clay, starch, toothpaste, and ice. The history of pica should be thoroughly searched for a woman having poor weight gain during pregnancy and refractory anemias. Why pica occur during pregnancy? The exact reason is not known, but it is suspected to be the hormonal changes of pregnancy. In the mouth, the pH and the production of saliva are unchanged during pregnancy. Botulism is an unusual complication of pregnancy associated with the loss of 1 to 2 liters of saliva per day. It is more common in a pregnant woman having nausea. It is believed to be inability of nauseated woman to swallow the saliva. It is not due to excessive production of saliva. Gingivitis of pregnancy, it is swelling of the gum during pregnancy. And there is Epulis gravidarum, which is a tumorous gingivitis associated with perfused blood loss with touching, like toothbrushing. If you see the stomach, the tone and the motility of the stomach and the gastroesophageal sphincter is decreased during pregnancy. The gastric emptying time is unchanged, except in labor, gastric emptying time is increased. So this increment of gastric emptying time in laboring mothers will increase the risk of regurgitation and aspiration with the use of general anesthesia in laboring mother. Pregnancy causes increased the risk of gastroesophageal reflux disease and dyspepsia. It was reported to occur in 30 to 50% of the pregnant women. This increment of gastroesophageal reflux disease is multifactorial and attributed by different factors. One factor is dysmotility of the esophagus. The second is decreased gastroesophageal sphincter tone during pregnancy. The third factor is gastric compression by the enlarged graviduterus. The fourth factor is estrogen-mediated reflex of acid toward the esophagus. The other is during pregnancy, the peptic ulcer disease risk will decrease in contrary to gastroesophageal reflux disease. Why it decreased? There are theories. Because of the increased placental histaminase synthesis, which decreased the maternal level of histamine, there is an increased gastric mucus production, which is said to be protective, reduced gastric acid secretion, and enhanced immunologic tolerance to Helicobacter pylori. When you see the intestine, disturbance in the motility of the small intestine and the colon is common during pregnancy. For this reason, some women report constipation, the others report diarrhea. If you see constipation, 35 to 39% of the women report constipation in the first trimester and 21% in the third trimester. So why the GI motility decreased during pregnancy? Because of the progesterone and the nitric oxide mediated relaxation of the GI tract musculature. So despite these alterations in motility, absorption of nutrients in the small bowel is unchanged, except iron and calcium absorption is increased, and also enlarged uterus displace the intestine and move the position of the appendix, make the diagnosis and the management of appendicitis difficulty during pregnancy. When you see the gallbladder emptying time is much slower during pregnancy because of the progesterone mediated inhibition of gallbladder contractions. And also during pregnancy, the biliary cholesterol saturation is increased and the chandoxycholic acid is decreased. This change in these two factors contribute the increased risk of gallstone formation during pregnancy. When we see the liver, the size and the histology of the liver are unchanged during pregnancy, but there are many clinical and laboratory signs that occurs in a patient having liver disease that normally occurs in pregnant women. Let us see spider angioma and the pulmonary edema increased in normal pregnant women because of high level of estrogen, serum albumin, and the total protein levels decreased during pregnancy because of hemodilutions, and alkaline phosphatase rise 2 to 4-fold because of the placental productions. The other liver function tests and the liver enzymes like bilirubin, LDH, AST, LT were unchanged during pregnancy. Thank you for watching, and don't forget to subscribe my channels to have more videos, and see you on the comment.